Thanks very much, Orla, and thank you everybody for coming. I'm very excited to be here. And so yes, my name is Jernström, and I'm going to be talking about my project, Grandparental Health Shocks and Adult Children's Fertility Choices. And I'll say a few words about the phrasing here. So since I will be having 3 generations here, so to be very clear, I will be referring to the first generation as grandparents, regardless if they have grandchildren or not, but just to be very clear on that, and maybe you can give me your opinion on that as well towards the end. So first, to start with that. And then what about my outline? So I will be motivating a little bit, talking about the context first. Then I will go to the data and institutional setting, and then over the identification, and then to the results. So to motivate a little bit. So health shocks in the family. So we know that population is aging, and through medical advances, more and more people are going to be affected by grandparental non-fatal health shocks, so hospitalizations, and most people are affected by grandparental death. And we know that family health shocks can spill over to other family members in terms of labor market outcomes and health. And we know that parental death has been found to affect a broad range of outcomes of the children, including health, marriage, education, and labor market outcomes. And we know that grandparents influence the fertility behavior of the children. So grandparents are an important source of financial and non-financial support. And they have been found to affect children's fertility decisions through provision of informal childcare, and a positive association between grandparental investments and fertility has been found in Finland and other Western and Nordic countries. And there's this paper by Chang and Lu, 2018, that comes quite close to this one. So they find a positive association between grandparental health and fertility in Taiwan. So I asked, do grandparental health shocks affect the fertility behavior of the adult children? So in this paper, I examined the effect of grandparental health shocks on adult children's fertility behavior. And there might be compounding factors or reverse causality. And so, of course, in an ideal experiment, health shocks would be randomly distributed across individuals. And well, this is unlikely in real life. So I exploit the plausibly random timing of a grandparental health shock within a short window to get to causality. So I use difference in differences strategy using individuals who are treated in the future as controls. And so why would grandparental health shocks affect fertility? So it can be a resource question. So couples are likely to consider extended family resources when making fertility choices. There's a long tradition of literature on this. And grandparental health shock is a shock to resources. So there might be changes in labor supply. So possibly the grandparents who gets ill, they might reduce their working hours, or they might retire early. And this way they might be spending more time at home and might have more opportunity to take care of children and provide informal childcare. And of course, it can be that the spouse of the grandparent who gets ill might also reduce labor supply in order to provide informal care, which is quite common in Finland as well. And also the adult children might reduce their labor supply and provide, in order to provide informal care for their sick parents. And there might be effects to mental health or health spillovers. There's evidence on this. And so essentially the effect of resources on fertility is largely ambiguous. There might be income and substitution effects. So essentially changes in labor supply and childcare. And what does economic theory say about this? So parental health shocks basically revealing negative information on own health and life expectancy, and a shorter investment horizon due to this health shock should increase fertility and favor earlier childbearing. There's quite large literature on the relationship of life expectancy and fertility. And so why would this be? So all else equal, the shorter investment horizon should mean lower returns on human capital investments, and there might be quantity quality trade-off towards more children and less investment on quality. And then we know from psychology, there's the attachment theory that says that when there's a health shock in the family or a shock, the individuals might act proximity seeking in response. So the relative importance of family may increase, and there might be this effect that adverse events unite. And then there's this replacement insurance theory that says that when individuals get this effect that life is fragile, they might insure against loss of family members and increase fertility. And they might realize that waiting is essentially risky. And so my contribution, so while we know that grandparental health shocks may affect the determinants of fertility, for example, life expectancy, marriage, or family resources, my contribution is to be the first to provide causal evidence on the impacts of non-fatal and fatal grandparental health shocks on fertility. And I also provide evidence on the effect of grandparental health shocks on annual earnings, mental health, and marital status of the adult children. So to give a preview of the results, I find that an unexpected parental hospitalization increases the probability of birth by 12% or by 8 additional births per 1,000 affected individuals 3 years after the shock. And to the contrary, I find that a grandparental death decreases the probability of birth by 14% or by 6 less births per 1,000 affected individuals 4 years after the shock. So this might suggest that there might be different mechanisms at play for these non-fatal and fatal health shocks. So then to give an idea of the data and institutional setting, so I combine several administrative Finnish registers with family linkages from 1987 to 2017. And I get data from the Finnish Institute for Health and Welfare. This is the data on primary healthcare services, which includes all inpatient hospitalizations. It's where I get my non-fatal health shocks and the mental health outcomes. And this I combine with the register of all births in Finland. And this I merge with the data from Statistics Finland, which is the cause of death information, and the demographic and labor market information, which is the matched employer-employee data. So in the end, I have a panel that compasses 3 decades on 3 generations. And I have information on the health and labor market outcomes, cause of death, and fertility of all residents in Finland since 1987 to 2017. I restrict my sample to 24 to 45-year-old women who experience a grandparental health shock at some point in my panel. And I define my non-fatal shock variable as the first grandparental hospitalization due to a heart attack or stroke, conditional on surviving for at least 4 years and having no previous hospitalization before. So this is in order to have an unexpected health shocks. This is why I use the heart attack and stroke, so would have little anticipation effects. And then I define my fatal shock variable as the first grandparental death due to a heart attack or stroke. And I condition on that the other parent is still alive and no previous hospitalization due to a heart attack or stroke. And my main outcome variable is the probability of birth and a given relative time. And then what about the institutional setting? So the Finnish institutional setting is, we have quite extensive public subsidies for parental leaves and childcare arrangements. The total paid leave for mothers includes maternity leave and cash for care home care allowance that's available until the youngest child reaches the age of 3. And there is a universal right to publicly funded daycare services for children under school age. So then to the identification. So basically I follow Fadler and Nielsen and others and use the plausibly random timing of a health shock within a short window in time as the source of exogenous variation. I take only the affected, so the people who experience a given shock at some point in the panel. I fix a group of cohorts and compare individuals who experience a health shock at time t, this is the treatment group, and to individuals who experience the same shock but at time t plus delta. So this is the control group. And throughout the analysis, I will use delta 5, so 5-year window. Individuals are this way similar in observables and in expectations, but differ in the exact timing of the shock within a short window. And my identifying assumption is that absent the realization of the shock, the trends would run parallel. And then the same more formally. So here is my empirical specification. So on the left-hand side, there's the outcome for individual I at time t. So for example, probability of birth. On the right-hand side, there's the indicator treat, which equals 1 if an individual belongs to the treatment group and 0 otherwise. There are the indicators IR, which are time relative to the shock year. And their interaction gives the delta R, which is the parameter of interest, and gives the period R treatment effect compared to the baseline, which is -1. X is the vector of controls, which includes age, calendar year, and parental birth year fixed effects. And then delta is the window such that control group becomes treated at time delta. So then there's this trade-off between the length of the follow-up period and similarity of treatment and control groups. And then to take a look at the covariate balance of my samples. So here on the y-axis, there's a group of background characteristics at baseline -1, which are standardized. And here I've individually regressed them with the indicator treat. So overall, on the left-hand side, there's the non-fatal shocks, and on the right, there's the fatal shocks. And overall, the balance seems quite good, with few exceptions. So for non-fatal shocks, the treated are slightly more or have slightly more annual income at base year. So I control for this in the specifications. And for fatal shocks, the treated have slightly less education and are slightly less likely to have children. So I control for this in the specifications. But overall, the differences are quite small. So then to the results. So here is the effect of non-fatal grandparental hospitalization on the probability of birth. So first to go over the non-fatal shocks. And the outcome is probability of birth at each relative time. So overall, the pretrends look quite good, and we see a positive impact of a grandparental shock 3 years after the shock, so with a bit of a lag, possibly inherent with the outcome. So, and then this effect amounts to approximately 12%, or 8 additional births per 1,000 affected individuals 3 years after the shock. And then for fatal grandparental shocks or grandparental death, there's an opposite effect. So again, the outcome is the probability of birth at each relative time. And again, the pretrends look quite good, and there's quite an immediate effect, which is still seen 4 years after the shock. And this effect 4 years after the shock amounts to approximately 14%, or 6 less births per 1,000 affected individuals 4 years after the shock. And then we can look at the average effects. So here I regress the probability of birth with the main effects of post-period and treatment indicator, and then the interaction post-treat. And in column 1, there's the results for non-fatal shocks. And then in column 2, there's the results for fatal shocks. So again, there's looking at column 1, there's a positive effect for post and treat for non-fatal shocks. And for fatal shocks, the effect is negative. So possibly these results suggest that there might be different mechanisms at play for these shocks. They don't just go with the intensity of the shock as might have been expected. So then to think about the channels. So first I've seen or looked at the non-fatal shocks. So first I've thought about the availability of childcare. So as I said, grandparental health shock may lead to changes in labor supply, so maybe early retirement or informal care by the spouse. And this way they might have more available time at home, which may also lead to an increased opportunity for childcare. So I find exactly this. So there's a reduction which is quite economically meaningful, especially for the grandfathers, and also effect for grandmothers. So here you can see online there's the probability of being employed for grandmothers when a grandfather gets a shock, and conversely to with the dashed, there's the probability of being employed for grandfathers when a grandmother gets a shock. So both we can see a reduction 4 years after the shock. Then I've also looked at physical proximity. Right now I only have municipality level data, so I'm hoping to get a bit better data on the actual physical distance between the parents and the children. So now I've just looked at by whether the grandparents and the children live in the same municipality or not. But now with this measure, I find no differences. Also a bit of out of power here, a bit messy picture, but nothing clear on that. Hoping to get a bit better data on that. And then I've looked at the annual earnings of the adult children. So possibly they reduce their labor supply in order to be able to take care of children or room for family extension. So I find a reduction in annual earnings, which amounts to 5% 4 years after the shock. So I find some evidence for the availability of childcare playing a role here as a mechanism why I see a positive effect on fertility following a non-fatal health shock. Then I've looked at burden of care because increased burden of care could reduce fertility, and I've looked at by whether the effects by whether the child is an only child and supposedly has more burden of care, and then because evidence suggests that especially women bear the burden of care of their parents among siblings, I've looked at by the results by whether the individual has any sisters or not. And I don't find any evidence for burden of care, also a bit of out of power here, but if anything, the individuals who are only children are higher in fertility, but this is also very hard to say anything very conclusive on this. And for the sisters, don't find any differences. So it could be that as there is no significant burden of care effects, there might be more room for family extension, and this is why I see the positive effects on fertility. Then I've looked at the mental stress channel, so mental health and divorce. So I've looked at hospitalization due to depression or anxiety, basically, as a measure for mental health, and then the probability of divorce. There's some evidence that in the literature that these might play a role. But again, I find no clear evidence. Now I've looked at the average effects. So on column 1, there's the effects on mental health, and in column 2, there's the effects for divorce. While the coefficient for the mental health effect is quite large, appears to be statistically significant, and essentially no evidence for any increase in probability of divorce. Then I've tried to think about if there could be other mechanisms for grandparental death, and maybe you might have any suggestions. I would be very grateful. Thus far, I've not really found any clear evidence what could be the difference here. I've looked at the availability of childcare, and again, I find a reduction in grandparental employment, which is slightly smaller than for non-fatal health shocks. Because again, possibly following the death of a spouse, the other grandparent may reduce their labor supply or retire early. And this might again lead to an increased opportunity to provide informal childcare. And I've looked at annual earnings, but the reduction is only 2% now, so not very meaningful. So there might be some evidence for possibly, or hard to really say if the availability of childcare would here play a role. Of course, it could be now the grandparental employment can also lead to reduction in financial support. So maybe reduction in employment can cause a reduction in financial support because there's less labor market income, and maybe this can have explain the negative effect on fertility, so as to have to be an income effect, but difficult to say anything very certain. I've looked at the mental stress channel. So again, mental health and divorce, because there's evidence that there's this paper by Böckerman, Haapanen, and Jepsen, who find negative mental health effects by gender following parental death in youth in Finland. And then there's also this other paper, Oysten and Krunchik, which I'm not sure if I'm pronouncing correctly, but they find negative mental health effects following parental death in Norway. And then there's some evidence that a parental death may decrease the probability of marriage for sons, which can then lead to changes in fertility as well. But again, I find no clear evidence on these effects. Again, the coefficient for mental health is quite large, but fails to reach statistical significance, and same for the divorce. Then I've looked at some heterogeneity of the results. So I've looked at if the results are different for couples with prior children and without. They might act differently in response to a health shock. Possibly the families with children might be more flexible in changing the number of children, but there might be also substitution effects that are different. So I find that for both non-fatal and fatal shocks, the effects seem to be driven by families who already have children, so they correspond the results for the blue line to the main effects. And then I've looked at the heterogeneity by gender of the grandparents, so whether the shocks are different by whether they come from the maternal or paternal side, because there's evidence that there might be heterogeneity by gender. And there's evidence suggesting that especially grandmothers invest in their grandchildren, but I find no clear evidence. But also these are quite messy pictures, a bit out of power here, might say. Yes, and then to conclude, so I have examined the impact of grandparental health shocks on fertility and find evidence of effects on fertility behavior of adult children. So I find that an unexpected grandparental hospitalization increases the probability of birth by 12% or by 8 additional births per 1,000 affected individuals 3 years after the shock. And when looking at the mechanisms, it seems that availability of childcare might play a role, and there's no burden of care effect, so this might allow more room for family extension. And I find no clear evidence on mental stress channel being a burden, which also can support the positive fertility effect. But then conversely, I find that grandparental death decreases the probability of birth by 14% or by 6 less births per 1,000 affected individuals 4 years after the shock. Bit difficult to say anything certain of the mechanisms. Grandparental employment goes down, so this might speak to an income effect, but yeah, no evidence on significant mental stress effect. And then a word about the policy implications. So health shocks can affect fertility behavior. So assuring individuals against risk to key neurosocial networks may be effective form of family policy. Targeted interventions around the events can be effective and could be considered in policymaking. And since the cost of health shocks exceed beyond the individual, accounting of overall effects of family health shocks can be important. So that's all that I have for now. So thank you a lot for your attention.